Hello everyone, welcome to my slidecast of my lecture on infectious lung disease and its diagnosis. The learning outcomes are listed on the first slide. I'm not going to read them as I will be using them to signpost where we are throughout the lecture. But first of all, to give a bit of context, infectious lung disease is a massive global burden. It's estimated that there are about 450 million cases and 4 million deaths from pneumonia every year in the world, and 2 million under 5 die of pneumonia throughout the world every year. That's more than of any other single disease syndrome. In the UK, it's estimated that there are about 250,000 adult cases and 300,000 child cases per annum. The case fatality rate for pneumonia is about 1% if it's managed in the community, but that rises to 30% if the patient's hospitalised and requires intensive care. So these diseases are a huge burden on healthcare systems worldwide. Our first outcome is to define terms associated with infectious lung disease. And as always, we need to think anatomically. Here's a diagram of the respiratory tract. If in the upper respiratory tract, we can have rhinitis, pharyngitis, laryngitis, and then coming down into the lower respiratory tract, tracheitis, bronchitis, bronchiolitis, and pneumonia, which is inflammation and infection of the lung substance. Empyema thoracis, or pleural empyema, is pus within the pre-existing pleural cavity, and lung abscess is pus within the lung substance. Cavitation is literally this, formation of a hole within the lung substance. You can see this is a post-mortem specimen, which shows extensive areas of cavitation where the lung has simply rotted away. There are a number of common syndromes of infectious lung disease which we're going to deal with in this lecture. These are bronchiolitis, inflammation of the bronchioles, infective exacerbation of COPD, influenza-like illness, pneumonia, although I won't go into great depth as you had a lecture from Mark Bailey on this last year and I'd urge you to revise that, empyema thoracis, bronchiectasis, lung abscess and tuberculosis. Tuberculosis is a very important member of this list, but I am not going to deal with it in this lecture as Martin Dedicote is lecturing later this week and I shall leave it to him. He has seen more cases of TB than I have had hot dinners. So our first syndrome, very common if you're in general practice this winter or in paediatric admissions, my baby's wheezing. Our case is of a 5-month-old fully immunised child born by elective caesarean with 2 older siblings who were both healthy. The baby was breastfed for 2 months and is now bottle fed. Mum brings him to the GP complaining of a day of temperature, cough and a wheeze following a really snotty nose. GP takes a look at the baby, sees respiratory rate is 65, which is high for a 5-month-old. SAT's a bit low at 91%. Baby's showing nasal flaring, intercostal recession. When he puts the stethoscope on the chest, there's a widespread wheeze. GP takes the immediate decision to send this baby to paediatric admissions. That's based on current guidelines. This one's the SIGN, the Scottish Intercollegiate Guideline Network here. We're still allowed to use the Scottish guidelines as they voted to stay in the UK. The NICE guidelines are pending but not yet available. So what is bronchiolitis? Very simply, it's the inflammation of the bronchioles. This is what you can see here. You have the bronchiolar wall muscle and the aperture of the bronchiole is the lumen, is entirely filled with inflammatory cells, coloured in purple here. You can see this is basically blocked off a bronchiole, so not a lot of air is going to get through. That causes the respiratory distress and also the wheeze as the air squeezes through the cracks. Bronchiolitis is really common in childhood. It's viral, and 70% of cases are estimated to be caused by respiratory syncytial virus, this one RSV. It is the single major cause of admission to hospital in children under 1 in this country, and it's highly infectious, reaching epidemic levels in the winter months. By the age of 2, 80% of children have antibodies to RSV, so most will have been exposed, though not all will have got clinical bronchiolitis. The symptoms and signs are as of the baby who presented to our general practitioner. The child is very distressed, and often the parents are too. There's respiratory distress with signs of using accessory muscles, there's intercostal recession and nasal flaring. Sometimes there's wheeze, although not inevitably, and often particularly noticeable in the younger children, there's poor feeding. If you're struggling to get enough breath in, you don't want to put a milk bottle in your mouth and get it in the way. And the children are often therefore very lethargic. Most frightening of all for parent and child is apnea, a temporary cessation in breathing. How do you manage bronchiolitis? Well, basically it's supportive therapy. Unlike our baby, the vast majority of these are managed in the community and recover over a period of about a week to 10 days, which can feel very long if you're a parent with a sick baby. Supportive care requires fluids, nutrition, antipyretics, and of course very careful safety netting to return if the baby becomes worse. Admission is required if there are markers of severity, as listed in the guideline that I linked to earlier. But basically in hospital, care remains supportive, oxygen can be added, NG feeding if the child is failing to take in enough nutritional fluids, and a very tiny minority will be ventilated. Because RSV is so very infectious, infection control is vital in a hospital environment if you're not to infect otherwise unaffected children. Babies with bronchiolitis will be isolated, though often the numbers are so high that they're cohorted together. Personal protective equipment will be worn by nursing staff, and careful hand washing is required to avoid spreading the virus from baby to baby. Prevention of bronchiolitis then basically requires hygiene. There was an RSV vaccine developed previously, but unfortunately it was found to make disease worse, not better. However, passive immunisation might have a role in those patients at the highest risk of severe disease, basically the ones in this list over here, under 6 months with pre-existing cardiac or pulmonary disease. Passive immunisation is where the child is given antibody in the form of intravenous immunoglobulin, which then mops up virus and may attenuate the illness. Outcome: the vast majority make a full recovery, although up to 50% will wheeze recurrently with further childhood viral infections. The mortality is low at 8 per 100,000, and the vast majority of these will be in this group of patients. So that's bronchiolitis. Now we'll move on to our next infectious lung syndrome. And this is an even more common presentation, I would say. Again, many of you will be out in general practice or in the medical admissions unit. I need some antibiotics, doctor. This is a 68-year-old lady who comes to her GP complaining of a cough productive of mucky sputum, and you're really lucky because here is what it looks like on her tissue. She takes it out of her pocket to show you. Try not to gag. She's breathless on climbing stairs, and on further questioning she says she smoked 20 a day for 40 years, but she gave them up 3 years ago. When pushed, she said she gave them up because she was producing more of this mucky sputum and it was starting to bother her. This is obviously signposting you towards an infective exacerbation of COPD. So, how do we define an infective exacerbation? Using the NICE and BTS guidelines, which are found here and are extremely comprehensive, we would usually define it as 2 out of 3 of more sputum, more purulent sputum, and the patient is more breathless. As I say, the guideline is here. It's very long. Don't read the whole thing, but the summary is very useful. Should you send or should you not send the sputum? The BTS guideline suggests that the patient should have their sputum sent, but that antibiotics, if you think they're required, should be started empirically. If you send a sputum, what are you likely to see? Well, just a quick reminder of what's in your sputum. Sputum is expectorated through the upper respiratory tract, and so you'll get saliva, often quite a lot of saliva. Sometimes something labelled as sputum is solely saliva. If you go looking for them, you'll find epithelial cells from the mouth and respiratory tract. And then if you have inflammation, obviously you'll have inflammatory cells, neutrophils. What else? Well, then of course there's the germs. There'll be lots and lots of viruses from the mouth, the respiratory tract in that sputum. We don't usually look for them, although we can. And then there will be the bacteria. Commensals, those which are always there and doing no harm. Organisms which can be pathogens under certain conditions, and those which are always pathogens. And in addition, we often find fungi in sputum if we go looking for it, particularly from the mouth. However, in general, unless we're specifically asked, we won't test the sputum for fungal presence. Back to our COPD patient, probably 50 to 70% of exacerbations are infective, and 20 to 40% of those are caused by viruses, the most common being rhinovirus, which causes the common cold, adenovirus, our old friend RSV, respiratory syncytial virus, and influenza. RSV deserves another mention because I told you previously that 80% of 2-year-olds have antibodies. However, sadly, those are not protective antibodies, they are merely markers of prior exposure, and people remain susceptible to RSV throughout life and can go on being reinfected. In addition to the viral causes, there are bacterial causes, which are estimated to cause around half of all exacerbations, half of all infective exacerbations. Sorry, no, right the first time, half of all exacerbations. The principal bacteria implicated are Haemophilus, Strep pneumo, Moraxella, and then the gram-negatives, including E. coli and Pseudomonas. As you can see over here, the decreasing frequency of isolation, these ones at the bottom, are the least common. The sharp-eyed among you will have noticed that 50% plus 20 to 40% doesn't add up to my 50 to 70%. And that merely reflects the difficulty in determining which potential pathogen is actually causing an exacerbation, and indeed in working out whether, if you have co-presence of rhinovirus and Haemophilus, for instance, whether they're both responsible for the exacerbation or whether it's only the one. If we have a patient with an infective exacerbation of COPD, how do we manage them? Well, it's very important not to just use antibiotics. There's a whole package of interventions recommended in the guidelines. It includes bronchodilators, steroids, antibiotics if indicated. The antibiotics should follow local guidelines, and at UHCW it would be amoxicillin or doxycycline. Prevention of exacerbation is very important, and all patients with COPD should be receiving influenza and pneumococcal vaccination. But it is important to note that there is no role for prophylactic antibiotics. These can just make the infections more likely to be with antibiotic-resistant organisms. And that's infective exacerbation of COPD. Now we can move on to our next syndrome, one with which I suspect you will all be very familiar. I feel rubbish. The influenza-like illnesses. In this case, we have a patient who's 27. She presents to her GP with a sudden onset fever and chills. She describes a dry cough and a runny nose and a terrible headache. She also feels achy all over. Why did she present to her GP? That's a very good question. NHS Direct, as was, would have us all self-caring for this syndrome, and indeed that's usually appropriate. What causes influenza-like illnesses? Obviously the influenza viruses, but also para-influenza viruses, adenovirus, RSV again, coronavirus, and of course very important to remember all the other diseases which can start off looking like flu and are the cause of all these terrible headlines that you get every winter, Dr. missed my meningitis, and so on. The presentation is very non-specific. The key is failure of progression of the symptoms to something worse. So that's influenza-like illnesses. Now, here's somebody who might well have had some influenza-like symptoms prior to this presentation. It's a 34-year-old man with mild asthma. Comes to his GP complaining that he's had 5 days of upper respiratory tract symptoms with sneezing, headache, and so on, and then develops a harsh cough productive of some really disgusting brownish sputum, which I haven't showed you this time. This man decided not to bring it with him. He complains of right-sided chest pain on coughing and inspiration, and he says he's short of breath on climbing stairs, which he's never been before, and indeed is a very unusual symptom in a healthy 34-year-old. GP takes a temperature, it's 38.9, respiratory rate is up at 28, pulse, he's tachycardic, but his blood pressure is okay, and on auscultation he proves to have poor air entry in the right middle lobe. GP sends him off for a chest x-ray, and this is what we see. Here you go. I hope this one is obvious and bar and door enough for you. What you have is a fairly normal looking left lung, but here in the right lung you can see you've got the wedge shape of consolidation in the right middle lobe. He's got a right middle lobe pneumonia. How do we manage him? Well, we follow the guidelines. Brilliant. There's a BTS guideline from 2009. Again, it's very extensive. Please read the summary. He will need antibiotics. You need to follow local antibiotic guidelines, but these will all typically cover the common causative organisms, pneumococcus, Haemophilus, and possibly the atypicals, which I'll come back to in a minute. And locally that would be amoxicillin with or without clarithromycin. So what is atypical pneumonia? It's one of these terms that's bandied around really rather a lot. However, like with a lot of medical terms, sometimes you need to pin down people a little more precisely and say, well, what do you mean? Some people use it to mean the clinical syndrome that presents other than with symptoms of typical pneumonia caused by streptococcus pneumoniae. That is, symptoms often where there isn't productive of sputum and no signs of lobar consolidation. Other people use it to mean the pneumonia caused by atypical bacteria or viruses, and other people use it radiologically to mean lacking lobar consolidation on chest x-ray. Hopefully you can see on this x-ray, in contrast to the previous one I showed you, that while you have changes of haziness throughout this right lung and bits of this left lung, what you don't have is any obvious knocking out of a lobe. So if we're talking about atypical bacteria, what do we mean? What is an atypical? Here's a picture you've seen before. This is the typical structure of a typical bacterial cell. Here you have outside the cell membrane the cell wall. When people are talking about atypical organisms, they usually mean lacking a cell wall here. If the organism lacks a cell wall, it's an intracellular pathogen because it doesn't have the wall to protect it in the extracellular environment. This is really relevant clinically because many antibiotics, including all the penicillins, act here on the cell wall. If your bacterial cell has no cell wall, the penicillins aren't going to work. Also, because they're intracellular pathogens, they're generally not amenable to regular culture on an agar plate. So if atypical bacteria cause atypical pneumonia, what are they? Well, the common atypicals are Mycoplasma pneumoniae, which causes an atypical pneumonia often in young people, often in epidemic years. We talk of having mycoplasma years, though we haven't had one for a few years now. Chlamydophila pneumoniae and psittaci, these used to be known as variants of chlamydia, and psittaci some of you may have heard of because it causes the illness caught from parrots called psittacosis. A very important cause in hospital terms of an atypical pneumonia, that is atypical in terms of presentation and radiology, is this one, Legionella, the cause of Legionnaire's disease. However, this is not a typical atypical and is not actually an atypical bacterium, it's an cause of atypical pneumonia, as I'll explain in a minute. Respiratory viruses are a very important cause. You can get a primary influenza pneumonia, primary varicella pneumonia, and a measles pneumonia. And then there are many other non-bacterial causes of pneumonia, which don't cause symptoms typical of a lobar pneumonia, including pneumocystis, which you may have heard about in the infections and the immunocompromised lecture. However, these are not usually included when people are talking about a list of atypical pneumonia pathogens. I've got my typicals and atypicals a bit mixed up. So let's talk about this one, Legionella, which you could call a typical atypical because it's a typical bacterium, or an atypical atypical because in fact it's not a typical of the atypical bacteria. Confused yet? Good. Right, Legionella, important cause of hospital severe pneumonia, both hospital acquired and community acquired. However, the bug has a standard cell wall. It's a gram-negative bacterium, but it is an intracellular pathogen. The disease occurs both sporadically and in outbreaks, and there can be a mild form, which is known as Pontiac fever, which essentially looks like influenza. Legionella can also cause a very severe illness, especially in older male smokers, and that's classical Legionnaire's disease, which has a mortality of about 10%. It's called Legionnaire's disease because it was first described in a bunch of American veterans who attended a conference and all caught the bacteria from the air conditioning unit of the same hotel. These particular American veterans were also known as Legionnaires, hence the disease. You need to treat it with antibiotics active against intracellular bacteria, which includes the macrolides, hence the clarithromycin on the antibiotic regimen I showed you earlier, or tetracyclines or quinolones like levofloxacin. So that's pneumonia. If you want more detail, please do go back to Mark Bailey's lecture from last year, which is still on your Moodle pages. Our next syndrome is empyema, thoracis or pleural empyema, which simply means pus in the pleural cavity. Spontaneous empyema is usually a complication of pneumonia and has become uncommon in the antibiotic era, where most pneumonias are treated and resolve. However, if it does occur spontaneously, these are the common causative organisms. This Streptococcus, which is particularly good at forming pus, Streptococcus pneumoniae, our commonest cause of pneumonia, Staph aureus, another great pus former, and anaerobes, including Fusobacterium from the mouth. You can get tubercular empyema, or it can be iatrogenic, following a pleural incision, including putting in a pleural drain. Clearly, if you make a hole in the skin, the organisms most likely to go into the pleural cavity are those found on the skin, and therefore we have top of the list Staph aureus, but also the gram-negatives, including E. coli. It's relatively uncommon to see empyema presenting in the community, but clearly much more common in hospital practice. The next syndrome we need to talk about is this one. Another fairly typical presentation to a general practitioner who, this lady has again brought her sputum pot with her, full of disgusting stuff with some saliva frothing on the top, as you can see here. She's a 59-year-old lady who's never smoked. Excuse me, sorry about that. And she complains of a cough productive of thick sputum for the last 3 months. When you look back at her records, you see that she's had 8 courses of antibiotics in the past 2 years for a chest infection, which seems really quite a lot. She's now complaining of being short of breath on very mild exertion. She can't get up the stairs properly, and she can no longer look after her grandchildren, which distresses her very much. On direct questioning, she says she was hospitalised with pneumonia 5 years ago, but she doesn't have any other medical history of note. You're, in this case, highly suspicious that she has bronchiectasis. Bronchiectasis has a prevalence of about 300 per 100,000, and women are affected far more often than men. It may present at any age, but the prevalence is highest in older women. No cause is identified in about 50%, but if a cause is identified, as it was, or at least a potential one in our case, it's most commonly post-infective after pneumonia, TB, pertussis or whooping cough, or any childhood respiratory virus infection, including measles. I said that you would be suspicious that this lady would have bronchiectasis. You wouldn't make the diagnosis on the basis of her presentation in clinic, because bronchiectasis is now largely a radiological diagnosis, and high-resolution CT of the thorax shows characteristic thickening of the bronchial wall. If you send the sputum that I showed you for culture, it's usually positive. In fact, it's probably nearly always positive, but that may not be very helpful in determining whether antibiotics are needed. The things we grow are typically organisms of the upper respiratory tract, including Haemophilus influenzae, but we see a higher rate of isolation of organisms which aren't typical colonisers, including Staphylococcus aureus and the gram-negatives like E. coli and Klebsiella, as well as Pseudomonas aeruginosa. How do we manage bronchiectasis? Well, there's a BTS guideline for that. Excellent. Here it is. It's linked to, again, it's a very long document. I would suggest reading only the summary. But notice when you do that nearly all the evidence is actually graded D. So there's lots of expert opinion, and that's what the guideline consists of, but there really is no data from trials or case control studies. I find it particularly interesting in a guideline that is recommending antibiotics that in general the BTS does not involve microbiologists and infectious diseases physicians on the guideline committee. In exacerbations, the guideline recommends you should use antibiotics effective against the organisms cultured. And this is just a note to remind me to point out that cystic fibrosis is a very important cause of bronchiectasis, but I'm not covering it further today because it will be covered later with the more complex cases. Our next syndrome is lung abscess. An abscess is a severe localized pyogenic infection in lung tissue. Here's a CT thorax where you can see actually you've got some consolidation here, but also you've got these things with some inflammation and holes in the middle with air. You've got abscesses forming here. They are now uncommon, again as a result of more widespread antibiotic treatment of pneumonia. The causes are aspiration from the upper respiratory tract and mouth and pharynx of pyogenic organisms, including Strep milleri and anaerobes. Also unresolved pneumonia. Particular causes of abscesses are Staphylococcus aureus and Klebsiella. You can get septic emboli from endocarditis, and this is probably the commonest cause I see in my hospital population, where we see intravenous drug users who've injected themselves with needles contaminated with their own or someone else's skin organisms. The Staph aureus seeds to their heart valves and then embolizes into the lung. You can get seeding of bacteremia of any cause to the lung tissue, and also, of course, penetrating trauma. Tumours can become secondarily infected, and you can have an abscess as well as a tumour, and if there's a foreign body left behind, then that's a seed point for infection to occur. In the real lecture, I let you all take a deep breath here, but as you can pause this at any time, I'm just going to move on quickly past the fun quiz as it's not part of the syllabus for examination. So our next learning outcome that we need to cover is applying the principles of microbiological diagnosis to infectious diseases of the respiratory tract. Hopefully you're now becoming familiar with the principles of microbiological diagnosis, microscopy, culture and sensitivity, or colloquially, see it, grow it, kill it. If you can't see it, grow it, kill it, you can try the alternative, detecting the organism by looking for antigen, protein that the organism contains, or nucleic acid using PCR or other amplification techniques. If you can't do any of those, you can try and detect the immune response to the organism, which is usually antibody detection. Microscopy of respiratory specimens. Well, for sputum, most labs now do not routinely do sputum microscopy, though if we're looking for TB, we do. However, the stains to look for TB are specific and different from other things, so it needs to be asked for specifically. We can do microscopy on other respiratory specimens. Here, this one happens to be a bronchial lavage fluid. And here we've done a special stain called a silver stain for this thing, pneumocystis. Microbiologists love changing names. Now I'm afraid PCP has changed its name. I'll let you read what it's called. Interestingly, the silver stain is not actually done by microbiologists, it's done by histopathologists. It's one of those historical things. So if you think there may be PCP and you want to look for it in lavage, you need to send a specimen to the histopathologists. After microscopy comes culture. Culture is still the mainstay of microbiological diagnosis for most specimens. Conventional culture will pick up most major respiratory pathogens. However, while culture used to be used for viruses, and that's what's going on in this picture here, you can see a cell culture bottle where the virus has been seeded onto a monolayer. This chap is looking down to see if there's any cytopathic effect on the cells. It's time consuming, it requires somebody who knows what they're doing, and it requires very clean conditions. Therefore, for viruses at least, culture has been largely superseded by molecular methods. These are just some of the things that we see from the respiratory tract growing on various plates. We've got some staph, some Haemophilus, some Moraxella, and some strep pneumo, and a sensitivity plate to remind you that we have to test them once we've grown them. Sputum culture. Well, as I alluded to before, sputum is expectorated through the upper respiratory tract, and the single commonest report you will get of a sputum culture is almost certainly upper respiratory tract flora, or mixed upper respiratory tract flora, or mixed oral flora. Of course, as I alluded to before, there's this overlap of upper respiratory tract flora and pathogens. If we see predominant growth of a pathogenic species, we're likely to pick it out and report it to you. However, there is an art to that, and so in order to provide you with the information you want, it always helps to provide us with the information we need. How do you interpret the result? Well, give enough information to us so that we can report out a relevant result to you, and always, always look at the patient, not just the result. We will routinely culture sputum for Streptococcus pneumoniae, Moraxella, Haemophilus. We'd also expect to grow a Staph aureus and other strep species. But there are some things that you need to ask for specially. And top of the list for that, although I said I wouldn't really go on about it, I can't miss it out altogether, is this thing. Tuberculosis. Requires special culture medium on funny looking agar that looks like this, but more commonly now in liquid culture, and other non-tuberculous mycobacteria. You have to ask for it specially or it won't get done. Legionella we can grow, special black medium that I showed you a picture of earlier on in the talk. You have to ask for it particularly, and it takes about 7 to 10 days. We can also grow Bordetella pertussis, the causative agent of whooping cough, but again it's difficult and fiddly, so you have to ask for it specifically. And we can grow fungi, but generally don't unless the patient is in intensive care or immunocompromised in some way. So if we can't see it or grow it, what do? We detect it. Seeing them may be hard. Here we have the electron microscope image of influenza virus. Fortunately, none of us actually have to run an electron microscope anymore. They are big, they are difficult to use, they take several hours to crank up, and they require some very experienced staff, which most labs no longer have. So if you can't see them very well or very easily, viruses in particular, therefore, we detect. If we can't grow them at all, and pneumocystis is a case in point, it doesn't grow in any culture system that we've yet developed. If it takes too long to grow them, most viruses, 7 to 10 days, intracellular bacteria, Legionella, although we can grow it and will do so, if you want an answer quickly, you need to do something else like detecting its presence. And often, particularly for viruses, it's just cheaper not to try and grow it, it's cheaper to do it another way. What do we detect? Well, antigen, we can detect a protein by using an antibody specific to the protein produced by the pathogen. Basically, the principle is that of a pregnancy test. You can do it as a dipstick, or here, this is basically a scaled up dipstick where you have the antibody on the wells of the plate and you put your sample in, and if you get a colour change, with a secondary antibody, then you have the presence of the antigen detected. We do quite a lot of Legionella tests like this. We also do RSV. You can also use fluorescent antibody to detect it. And again, this is actually a diagnosis of Legionella. You can see it requires a fluorescent microscope. It also requires somebody who's pretty good at detecting what's green splotch, which this is, and what's organism, which this is. This requires specific antibody, which is quite expensive. And increasingly, we are moving towards nucleic acid detection. It doesn't need any antibody. The pathogen doesn't actually have to be alive for you to detect its nucleic acid. DNA in particular, as you know, is very stable, and so we can even do it on formalin-fixed specimens that have been sent to histology. Nucleic acid detection is quick, relatively cheap, very specific because you design the primers against the specific bits of nucleic acid you want to find, and can be multiplexed. That means you put primers for lots of different kinds of pathogen together in the same tube and then detect all the answers. You can do it for viruses, particularly for influenza and RSV. Bacteria, we do it for tuberculosis and pertussis. And for fungi, it's particularly useful for the diagnosis of pneumocystis, much easier than the silver stain. Of course, it's not without its disadvantages. You don't get any sensitivity testing results if you don't try and grow something, although for TB, we can now get some genomics sensitivity results. If you do a multiplex, if you try and detect lots of things, it massively increases the chance of finding something, but the relevance of that may be much harder to interpret. So there are many commercially available multiplex respiratory pathogen kits, for instance, available. The one we used in my last hospital had 12 different respiratory viruses, but they included rhinovirus and various different coronaviruses, the pathogenicity of which is uncertain. We find reporting those out can cause a lot of unnecessary anxiety among clinicians. You also don't get any typing data if you're just doing simple yes or no detection, and in that case you may not be able to track the emergence and spread of infectious disease. If we can't directly detect an organism, we can instead try and detect the immune response to it, usually finding an antibody to the pathogen of interest. It tends to be very not timely, as in your patient will be better before you get an answer. So for most of the atypical pneumonia bacteria, you need a 4-week convalescent specimen to see rising antibody titers. Now clearly, if your patient is 4 weeks and convalescent, making the diagnosis matters less. In addition to testing for antibody, we can now look for activation of specific T cells, and this underpins the IgRA test for TB, which I think Dr. Dedicoat will tell you more about. So I'm going to take a deep breath and then move on to apply the principles of management infection to infectious lung disease syndromes. First and foremost, and always treat the patient. So go for ABCDE and sepsis 6 before you do anything else. If the patient is well enough, please take the cultures before antibiotics. But if they are not well enough, do not delay the antibiotic in order to take cultures. We can do direct detection or nucleic acid detection, particularly for pneumococcus legionella, at a later date if you've given antibiotics before being able to culture. And then the principles of giving antibiotics are always start smart and then focus. Start smart with the appropriate empirical antibiotics, that is best guess based on your clinical diagnosis and the local epidemiology, which will be known to the microbiologists who wrote your guideline. Smart antibiotic use, also known as stewardship, is a bit of a headline thing at the moment. You may have noticed that we have a problem with antibiotic resistance, and one of the important things that combat that is stewardship. Stewardship basically means giving the right drug at the right dose, at the right time, not leaving out the life-saving early treatment of sepsis, and giving for long enough. As I discussed in one of my introductory lectures, most of this right duration guideline is eminence, not evidence-based. And never ever use antibiotics where another therapy would be more appropriate. What are these other therapies? Well, very importantly, always, if there's pus, drain it. An empyema, for instance, always requires drainage and possible surgical clearance. If there's a foreign body, get it out. Aspirated objects are actually a cause of persistent cough and infection in children in particular. And if there's dead tissue, cut it off. What's the right drug? Well, it has to be effective against the likely or known pathogen. As I said, local guidelines will take into account both the common organisms for that disease and the common resistance patterns found locally. and then you can change it, the focusing, based on your specific culture and sensitivity results. The right drug has to be safe for your patient. Always, always ask them an allergy history. Look at their renal function, liver function, and other medicines they're on. And here the BNF is your best friend. It has a section on renal impairment, it has the sections on interactions, and will tell you what to do. And even better, it's now available online in all trusts, so you don't have to go looking for a paper copy at 2 o'clock in the morning. How do we determine whether an antibiotic is effective against the likely or known pathogen? Well, then we come to the antibiotic spectrum. You've seen a simpler version of this slide before, where we have gram-negative at this end and gram-positive at this end, and this is the antibiotic spectrum. So here we have broad-spectrum antibiotics that treat everything, gram-negative to gram-positive, or the other way around, and these include the cephalosporins, aminoglycosides, quinolones, and the extended-spectrum penicillins, which you will undoubtedly encounter patients on when you go onto the wards this winter. Then you have the narrower spectrum penicillins here, like amoxicillin, which has some gram-negative and gram-positive activity, but not as much gram-negative activity. Then you have the narrow spectrum penicillins, like Fluclox, which really only has anti-gram-positive activity. You have antibiotics which have activity only at one end or other of the spectrum, so here we go, vancomycin has no activity at all against gram-negatives. And here, aztreonam is a purely gram-negative agent. And then, not on the chart that I showed previously, we have these ones here, which have mainly gram-positive activity with a bit of gram-negative activity, particularly against the intracellular bacteria. And then we have the macrolides, erythromycin and clarithromycin, the tetracyclines and rifampicin. So, antibiotics for common respiratory infections. I've just reproduced a little bit of the UHCW guideline here. So for community-acquired pneumonia, if it's not severe, they would use amoxicillin plus clarithromycin. For aspiration pneumonia, comoxiclav. And for hospital-acquired pneumonia, comoxiclav plus gentamicin to increase the spectrum, particularly in the gram-negative direction, or the extended spectrum penicillins, piperacillin, tazobactam, plus gentamicin. Right dose? Well, it has to get to the site of infection and be active there. Has not to be inactivated by something that's present there, so lung surfactant actually inactivates some antibiotics. If you don't give enough antibiotic, you may well be promoting resistance development. Some antibiotics are toxic, and it's very important to monitor the levels of them within the patient's blood. The ones to watch out for particularly are aminoglycosides, of which far and away the commonest is gentamicin, but also vancomycin. All hospitals will have policies on how to initiate these, what to do in renal impairment, and how to monitor them. You must always follow local policy if you're to avoid damaging your patient's kidneys. In summary, we've defined lots of terms associated with infectious lung disease: bronchiolitis, bronchitis, pneumonia, empyema, cavitation and lung abscess. We've described the common syndromes of infectious lung disease, made lists of the common organisms causing those infectious syndromes, and hopefully applied some of the principles you already knew about microbiological diagnosis to infectious diseases of the respiratory tract. And then the principles of management of infection, principally antibiotic therapy, to the management of infection in the lung. If you want more information, it's present in the Moodle book. As I said, please do go back and revisit Mark Bailey's pneumonia lecture. The BTS guidelines are a mine of information, but I would suggest reading the summaries only as they're very long. Microbiology and Infection at a Glance is, I have come to decide, the best textbook for the course that I am delivering. And of course, you can always, always ask. Thanks very much for listening.